So, good morning, everyone. My name is Mary Malati, and I am a medical student at the University of Maryland. I would like to begin my presentation by first thanking Dr. Sama, who was my attending, who took time out of his busy schedule to offer guidance on my first case report today. So, this morning I will present to you a case of a middle-aged man who presented with invasive pneumococcal pneumonia as his primary symptom of multiple myeloma and some lessons to be learned. So, a 55-year-old man with history of substance use disorder, hypertension, and asthma presented to the ED with a 3-day history of diarrhea, nausea, and vomiting. He was found to have a fever of 101.2 and was hypoxic to 86% on room air. And a chest x-ray revealed an extensive hazy left lower lobe infiltrate concerning for pneumonia. His laboratory data was notable for leukocytosis of 22.5, anemia with a hemoglobin of 5.7, and an acute kidney injury with a creatinine of 8.9. His calcium level and paraprotein gap were within normal limits. Blood cultures grew streptococcal pneumonia, and a streptococcal urine antigen was also positive. And so this confirms the invasive pneumonia. So given such an invasive infection in an otherwise healthy man, the decision was made to investigate immunodeficiency. HIV antigen and antibody were found to be negative, and hepatitis and rheumatological workup were also negative. Here in figure 2 in the middle is a CT of the abdomen and pelvis, which showed a lytic lesion in the right iliac wing. And pelvic MRI in figure 3 also showed the right iliac wing lesion and a left femoral lesion and brought concern for neoplasm. The answer to this case was in the multiple myeloma and immunoglobulin deficiencies workup that were obtained. Both SPEP and UPEP showed a discrete band in the gamma region, and immunofixation showed a discrete lambda light chain band with trace IgG band. Kappa lambda ratio was low at 0.03, which meant that there is an excess production of lambda light chain. And a bone marrow biopsy was scheduled, but unfortunately the patient left AMA stating mistrust in the hospital system. A few weeks later, he presented to an outside hospital with similar symptoms of fatigue and anemia, for which an IR bone marrow biopsy was performed here in figure 4 and confirmed the diagnosis of multiple myeloma. So there are a few lessons to extract from this. As you may know, multiple myeloma is a clonal proliferation disorder of plasma cells in the bone marrow that usually presents with bone pain due to the osteoporosis, renal failure due to the light chain deposition in the kidney, fatigue, and weight loss. It's also known in the literature that patients with multiple myeloma have a higher susceptibility to encapsulated bacterial infections compared to the general population. And this is thought to be due to the diminished production of functional immunoglobulins and a defect in the patient's C3b binding capacity to strep pneumo to clear it from the body. And there are only a few cases reported with a severe bacterial infection as the primary presenting symptom of multiple myeloma. A review paper I found of 17 case reports from 1978 to 2008 of bacterial infection as the first presenting symptom of multiple myeloma summarized some of the findings. So musculoskeletal infections, specifically septic arthritis, predominated these cases, followed by pneumonia, which was 29% of these cases. The culprit was strep pneumo, which was found in 2/3 of the infections, followed by H. influenza. Bacteremia was also found in 80% of these cases. So the case I present to you this morning highlights the importance of considering multiple myeloma in previously asymptomatic middle-aged patients who present with severe bacterial infection without an apparent predisposing factor. In addition, this case report points out the challenges faced by some of our patients with concurrent comorbidities like substance use disorder or with socioeconomic challenges that may prevent them from staying in the hospital to get tests and obtain optical medical care, inpatient and outpatient. In an ideal world, patients would be treated for their infection in the hospital and then follow up at a hematology clinic to prepare for chemotherapy and potential cell transplant. But in the real world, there are many obstacles to managing this disease, which could delay diagnosis. And it is known in the literature that a delayed diagnosis of multiple myeloma decreases the time of disease-free survival. The last fact I'll share is that multiple myeloma is more common in older patients, particularly 65 to 74-year-olds, but my patient was only 55 years old. So future directions of study from this case report could be to investigate the age distribution of patients presenting with bacterial infection as the first symptom of multiple myeloma, so we can better manage the diagnosis of multiple myeloma in all our patients. So this concludes my presentation, and I would welcome any questions.
Very nice, Mary. And that was exactly just under 6 minutes. You know, I just kind of wonder, and all of you can put questions in chat, and Janaki, I guess, should be monitoring that.
Yeah.
But do you have any idea why the patient left AMA?
Yeah. So this patient is a heroin user, and it's multifactorial. I figured that he was starting to withdraw. By this time he'd been in the hospital for a week, and we were just waiting for tests to come back, knowing that he might not have great follow-up, and we wanted to establish care. But he was waiting around, and he didn't truly understand what he was waiting for. And there's a note from his talk to the chaplain saying that the hospital is just keeping me here to use me, and then he left. And so that's, I think, a common theme in a lot of patients in Baltimore City that I've worked with who have a misunderstanding of our intentions to keep them in the hospital. And unfortunately, the patient left, and there were multiple hospitals presentations to ED afterwards for this patient. So he was found down, and they gave him Narcan, and he left AMA again. And then he presented to the outside hospital and stayed long enough to get the IR bone biopsy. So it took a long time, and that delays the diagnosis and starting treatment as well.
Thank you. Any other questions out there?
Oh, sorry, I'm reading in the chat here. Anemia.
Yeah.
Janaki, you're doing that?
I was going to do it, but I was going to wait till everyone finished, because otherwise we're not going to get the others a chance to present. We have very little time. So
yeah, I'll be happy to answer later.
We should go ahead.
Mm-hmm.
So what's next, Janaki? Are you sharing screen?
No, I'm not sharing, but I'm controlling your screen. So if you give me DeConte's presentation, I can control the screen.
No, let's see.
You're making awful faces, by the way, Dr. Williams. Making these poor students feel that.
Thanks a lot.
Yeah, I'm just letting you know. I don't know if you're aware. I keep looking at my video to make sure
I have been told. I have been told.
Yes.
Oh, wait.
If not, I can pull it up. I mean, I think.
Why don't you do that? Because I'm having a little trouble with transitions.
Okay,
here.
then okay. Let me pull it up. Give me a second. For some reason, today's Zoom is not behaving like before.
Okay.
And I apologize about that. And let me see if I'm able to, and basically my PowerPoint also doesn't want to. I think it's sensing something abnormal about one of your presentation, Dr. K, and that's why it's not pulling it up. It just refuses to pull it up.
All right, wait a minute. I'm going to try again.
Try it, because if you are able to get it, do it, because mine, it's refusing. Microsoft says no right now.
Is this?
If I'm able to pull it, I'll just share it in a second.
Do we have it there?
Yes, that's it.
Yep. Okay, go ahead.
Is our audio good?
Yes, your audio is awesome.
Okay.
Okay, I'm going to start the stopwatch, DeConte.
Let me know when.
Okay, go.
This oral presentation will discuss a rare case of autoimmune hepatitis overlapping with primary biliary cholangitis in a 61-year-old male. A 61-year-old Caucasian male with a remote history of polysubstance use, including cocaine and alcohol, was referred to St. Agnes Hospital by his primary care physician due to elevated liver enzyme and jaundice of 3 weeks. The patient also reports intermittent right upper quadrant pain of 15 years, which has increased in severity within the last month. On physical examination, he had sclera icterus, yellow discoloration of his skin, and right upper quadrant tenderness on palpation. Notably, he had no prior history of jaundice or right upper quadrant pain. He also, aside from persistent right upper quadrant pain and jaundice, the patient remained asymptomatic while hospitalized, and his vitals were within normal limit. His LFT was elevated in a cholestatic pattern with AST and LLT greater than 5 times the upper limit of normal. Initial impression was that the new onset of jaundice was secondary to alcohol abuse, most notably relapse. However, his toxicology screen was negative for alcohol and drugs of abuse. His CT scan showed a mildly nodular liver with cholelithiasis, gallbladder wall edema, pericholecystic fluid. His MRCP showed no focal liver lesion, no intrahepatic or extrahepatic biliary duct dilation or obstruction, and he had a normal common bile duct. He did, however, had periportal lymphadenopathy with the largest lymph node 2.5 by 1.5 centimeters. Further investigation included a viral panel, which was reactive for EBV antibodies, non-reactive for Hep A, Hep B, Hep C, HIV, VZV, CMV. His autoimmune panel showed IgG greater than 2 times the upper limit of normal, his anti-F actin antibody greater than 3 times the upper limit of normal, and his anti-mitochondrial antibody greater than 2 times the upper limit of normal. He did have negative anti-nuclear antibodies and negative anti-smooth muscle antibodies. Autoimmune hepatitis is a rare condition with a female to male prevalence ratio of 4:1. Likewise, primary biliary cholangitis has a female to male prevalence ratio of 9:1 based on a 2018 analysis from the Hepatology Journal. We learned that no international gold standard exists for diagnosing overlap syndrome. The European gold standard uses the Paris criteria to provide objective diagnosis for clinician based on the following criteria. If the patient presents with 2 of the 3 following, including serum alanine greater than 5 times the upper limit of normal and IgG greater than 2 times the upper limit of normal, or they have smooth muscle antibody plus histological features showing interface hepatitis, then the patient is diagnosed with overlap syndrome. However, the American Association of Liver Disease has recognized a limitation with the Paris criteria and has recently written an article regarding the scoring classification to diagnose patients with milder form of overlap syndrome, thus preventing the progression of the disease. An important feature that we learned about this case is that the seropositivity of anti-F actin is consistent with the diagnosis of overlap syndrome and is found in 85% of patients with the disease. There are currently 3 classifications for autoimmune hepatitis. The adult onset of autoimmune hepatitis is seen with type 1, while type 2 and 3 classically presents in the juvenile population as well as women. In summary, this presentation demonstrates the importance of a workup for a non-alcoholic related causes, the treatment option for adult onset of autoimmune hepatitis overlapping with primary biliary cholangitis syndrome, according to the American Association of Liver Disease, recommends the use of low-dose corticosteroid and uridoxycholic acid. The prognosis for overlap syndrome is favorable with early diagnosis, but with milder forms that are missed, liver transplant and cirrhosis can occur. Thank you.
Thank you, DeConte. That is a fascinating patient story. So ANA and anti-smooth were negative, but anti-mitochondrial was a high titer. And what about the anti-liver kidney microsomal? Was that done?
No, that was not done, but that is very specific based on research for type 1 autoimmune hepatitis, but that panel was not run.
And the ALP phos was rather normalish. I think 136 or thereabouts, wasn't it?
Yes.
And I mean, you know, we think of PBC as being very cholestatic, very high alk phos, lots of itching. Are you confident in the diagnosis?
Yes, based on the research indicating that anti-F-actin is highly specific and sensitive for overlap syndrome, I'm confident that the patient was presenting with overlap syndrome.
But the 2018 paper, which talked about the new scoring system, right? And that was set by the American Society of Autoimmune Hepatitis, and they looked at primary biliary sclerosis and autoimmune hepatitis. One of their big criteria is that the ALP, the alkaline phosphatase to transaminases ratio, has to be less than 1.5, which it doesn't meet. It says that you need to have, and the scoring system is that if the score is greater than 21, then you are definite for the overlap syndrome. But if your score is less than 19, it's rejected. And if you look at the scoring says AST or ALT greater than upper limit of normal, which you have, ALP greater than upper limit of normal, which you do not have. Then it talks about immunological ANA, anti-smooth muscle, or LKM, which you don't have because you didn't do LKM. It says anti-SLA, PNCA, which you don't have. Anti-mitochondrial, yes, you have. Histological category, you do not have. Then it says viral markers could be positive, may not be positive. Drugs, yes or no. Alcohol, less than 25, more than 60 grams. So I am not sure you meet the criteria totally for the overlap. And I agree that you got to think about it, but I think you need to do a little bit more workup and make sure that this is truly overlap before you call it overlap, because nowhere in my reading for PubMed did I find that only having F-actin is enough for it.
Yes, but with the new criteria, as you mentioned, the patient had been sober for 4 years, so you would you don't add 4. So I know the classification is greater than 21, but he came close to 21. I think the higher the score, the more likely that overlap syndrome was present.
It's not higher the score. It's specifically greater than 21, greater than or equal to 21, 19 to 20, 19 and 20 are probable, less than 19 is rejected. So you don't have a whole bunch of these done. So that's why my worry is that you have to be a little bit more careful and you need to do some of these testing. I'm not saying he doesn't have it. Don't get me wrong. Not saying he doesn't have it. It's a great thought, but please look into that too.
Okay.
All right, let's, Lashmi, I think you're up next. Are you ready?
Yes.
Am I projecting?
Yeah.
All
right, whenever you're ready, Lashmi, I'll start the stopwatch.
Okay. I don't see my slides yet. I think you're frozen on the screen with all the files, or is it just me that sees that?
Can everybody see as I'm?
Yeah, it's also on the screen with all the presentations.
Yeah, you're on the screen with all the presentations. If you give me a remote control, then I can try, but even then I'm not able to open it because it's frozen. Not able to open it. You need to open it, boss.
So it's not there. Let's stop share.
Somebody has, is that you?
How about now?
Yes.
Yeah,
Got it. And I'll take remote control, so I'll move slide by slide then.
Okay.
All right, I'm ready to hit, and let's go ahead and start.
Okay. Good morning to everyone. I'm Lakshmi. I'm a third-year medical student from the American University of Antigua. And this, my case is based on a case of pseudo-Meeg syndrome with ovarian metastatic cancer that I encountered during my third year, during my internal medicine core. So before I start off, just a little bit of background. Pseudo-Meigs syndrome is basically a variant of Meigs syndrome, originally described as a triad of a benign ovarian tumor presenting with ascites and pleural effusions. And pseudo-Meigs is essentially the same thing, except it involves a malignant ovarian tumor. And with both of these cases, removal of the tumor will cause resolution of the effusion and the ascites. Now, the presentation, because of its vague nature, it's a diagnosis of exclusion rather than something you would think about at the very first thought. So moving on to our case description, we had a 70-year-old female who presented with shortness of breath and an increasing abdominal girth for the past 2 months. She'd also complained of increased sensation of bloating at that same time. Now, before she came in, about a month before she came in, she had a workup for 1 episode of vaginal bleeding. And they did a pelvic ultrasound, which found pelvic mass. But because she didn't follow up, she didn't actually come in to seek medical help until she had the respiratory symptoms. So when we saw her, her physical exam was significant for absent breath sounds on the right side and dullness on percussion on the right side as well, and shifting dullness in her abdomen. So we did a chest X-ray, which showed a right-sided large pleural effusion, and then we followed up with abdominal and pelvic CT, which, as you can see, shows a midline mass spanning approximately 13.3 centimeters. And at that point, we were very suspicious for Meigs syndrome. And because of the limitations at our hospital, the plan was to do a thoracentesis and then transfer her out to a tertiary care center for definitive surgical intervention. So when we did the thoracentesis, yielded about 1.5 liters of fluid, which was exudative in nature. And at that time, we also did a cancer antigen 125 assay, which revealed it was elevated, but while it's a non-specific marker for malignancy, we weren't particularly alarmed at this point because there have been other cases of Meigs syndromes that have been presented with elevated CA-125 levels. So it didn't really change our management at this point. And since we were going to transfer her out, we just needed to do the therapeutic thoracentesis. So she was transferred out the following day, and she had a surgical exploration done, which basically revealed a high-grade serous ovarian carcinoma with metastases to the omentum, the pelvic peritoneum, and the
That's okay. Yeah,
the pelvic lymph nodes. And to the pelvic lymph nodes. So at that time, we were very surprised to find out that it was metastatic disease. So I think this case serves to, I guess, emphasize the reason for cancer screening guidelines and even
Somebody else is speaking. Can you unmute yourself?
Go ahead, Lashmi, I can hear you.
Okay, and anyways, so the pathophysiology behind this is poorly understood, but it's been linked to a lymphatic obstruction due to the tumor, and also in recent years they've also implicated expression of vascular endothelial growth factors by the tumor, causing accumulation of fluid through increase in capillary permeability. Unfortunately, because again, the limitations at our hospital, we weren't able to check for VEGF levels or even compare them post-surgery. And I think something we need to learn from this is, first off, this patient probably would have never come back to seek medical help if it wasn't for her respiratory symptoms. And just seeing the way she presented, she had extensive metastatic disease, and that's something that would have fallen through the cracks if it wasn't for if it wasn't for a workup that required a high degree of suspicion. And our case just serves to reaffirm the need for proper screening guidelines, and also to hold postmenopausal women of a advanced age that present with ascites and pleural effusions for an ovarian malignancy. And that's all.
Thank you. Yeah,
So
another
sorry.
another situation where our patient left the hospital rather than being able to follow through in a timely fashion. Go ahead, Janaki.
So a couple of things that I want to bring to your notice. One is that pseudomiggs is not always malignancy, because struma ovari and benign ovarian cystic disease is also pseudomiggs. So that is one of the things you need to remember. So I would modify that. It's a very nice case. Boss, can you please bring back the CT, because I need to go over the CT for a second?
Janaki, you know, in the interest of time, I was trying, because it takes me a little while to get things called
Okay,
up.
that's fine. That's fine. So the CT that you showed us did not have much ascites. So did you actually tap the ascites? Because there wasn't much ascites.
No, we didn't tap the ascites.
So then all the abdominal distension is actually the ovarian carcinoma. There wasn't much ascites. There's just a little bit fluid in the cul-de-sac. So again, that's again something that when you present the case, that's something to bring in for. And yes, most of these patients and most of malignancies and other intra-abdominal conditions unfortunately oftentimes become much more prevalent when they cause respiratory symptoms. And that is a true thing, and it's a great case. And if you're going to present it elsewhere and or write it up, have the path.
Okay.
The path slides. So
Okay.
good case.
All right. Thank you.
All right, we're just trying to get the appropriate final. Sarah, you're up, and I'm trying to get our appropriate vignette up.
The one day I didn't log in early in Zoom, boss. The one day. There we
Well,
go.
I wish I had practiced a little bit on this transition.
No problem. If you bring it up, I can do everything.
That's what I'm trying to do. Let's see.
Okay.
Share screen. How we doing?
We're doing okay.
I mean, is it there for everyone to see?
Yeah, the secret behind the curtain. Yep.
All right. So, I mean, we can either. So let me get the stopwatch ready.
Yep.
Sarah, are you ready?
Yes, I am.
Okay. Ready, go.
Good morning, everyone. My name is Zahra Halim, also from the American University of Antigua. Today, I will be presenting a case of a retroperitoneal abscess, which is our secret behind the curtain. Essentially, these abscesses are quite rare and, in fact, potentially life-threatening given their indolent and rather variable presentation. They often occur following gastrointestinal or genitourinary infections or perforations. In the developed world, we see them in patients with Crohn's disease or in our pediatric population following appendiceal rupture. Now, in regards to their relation to biliary procedures, they're quite uncommon. However, they are associated with laparoscopic cholecystectomies. Today, I present a case of a retroperitoneal abscess following an open cholecystectomy, which in literature has been noted to be less than 1%. Sorry, if we can go back to the main one. Our patient was a 64-year-old gentleman who essentially presented to our emergency department with worsening abdominal pain, difficulty breathing, difficulty eating, difficulty sleeping for the past 3 to 4 days, and he had some mild nonspecific shortness of breath. He was a poor historian on presentation. However, he was able to convey that he did not have a fever, he was not vomiting, he did not have diarrhea, he did not have an HIV history, or was not on any immunosuppressive medication. He had a past medical history pertinent for hypertension, as well as untreated hepatitis B and hepatitis C.
Additionally, he had a history of heavy alcohol use as well as opioid use, and he was a chronic smoker. So on initial presentation, he was quite hypotensive, tachycardic, but afebrile with a BMI of 13. He was quite ill appearing, very malnourished. He was a little bit in and out, incomprehensible, difficult to follow. And on physical examination, he had some mild nonspecific abdominal tenderness, but his FOBT was positive. His initial labs revealed anemia down to 4.6, leukocytosis, thrombocytopenia. His electrolytes were quite deranged, and he had metabolic acidosis with a lactate of 3. He had a positive sonographic Murphy sign, as well as dilated gallbladder on bedside ultrasound. So given this and his instability, he was upgraded to the ICU, which you'll be able to appreciate on the next slide. On admission to the ICU, everything was done. He received his 1 unit of RBCs, IV fluids, PPI. His hemoglobin jumped up to 9. He received the appropriate pressure support. However, his clinical condition did not improve. With high suspicion for a GI pathology, a CT angiogram of the abdomen was done, as we can see in this image here. And on the axial plane, you're able to appreciate with the black star that there is a rather enlarged gallbladder with pericholecystic fluid and some stones near the bottom end, as you're able to appreciate. And on the sagittal side, on the right side with the white arrow, we are able to see some free fluid in the abdomen, but no apparent abscess. So given this, he had an urgent cholecystectomy, open cholecystectomy done, which revealed gangrenous cholecystitis and retroperitoneal exudates. He had a drain placed, he was returned to the ICU, and he began to improve with the appropriate antibiotics. And about 3 to 4 days later, he was successfully extubated as he was improving and downgraded to the medical floor, as we will be able to see on the next slide. On the medical floor, though, about day 5 to day 6 is when he essentially began to deteriorate. He became less alert, rather, and there was increasing purulence from the site. His appetite became worse. He was just barely tolerating his liquid diet. So given this, the antibiotic course was extended. Despite this, he did not improve. So another CT abdomen was done, as we can see here in this image, revealed a rather large retroperitoneal abscess, which was multiloculated. So if you look at the right side sagittal image with the white arrow and the black star, it extended all the way down to nearly his scrotum. So it was quite large. So this warranted IR-guided JP drains, which did relieve quite a bit of purulent exudative fluid. However, it persisted. So there was a growing concern for potential obstruction in the biliary tract. So a HIDA scan was done, and that revealed a kink in the distal part of the common bile duct associated with a biliary leak and some fluid as well, with the dye exhibited in the paracolic gutters. So given this, it was confirmed with an ERCP, a sphincterotomy and a stent was placed in the distal part of the common bile duct, which significantly improved his symptoms over the next week, after which he was successfully discharged to a nursing home with up to a month of antibiotics and was followed up 2 months later for stent removal. So this case essentially emphasizes the importance for early detection and having a low threshold to consider retroperitoneal abscesses. Although there's no established criteria for their diagnosis, some risk factors that we saw in our patient was his male gender, his malnutrition, and his older age. And I would like to highlight that the distal part of the common bile duct is retroperitoneally located, hence an obstruction here, whether that's through a stone or damage with procedures such as an open cholecystectomy, can potentially allow for seeding of the bilious fluid and the bacteria into the retroperitoneal space. And the mainstay of management, as we have performed during his admission, which was quite long, was the source control with the cholecystectomy, stent placements, IV antibiotics, as well as nutritional support. So 3 take-home points I'd like to highlight today is it's really important to consider a retroperitoneal abscess as a complication of cholecystectomy and potentially have a low threshold so we can improve or diagnose it earlier and potentially improve our outcomes. The abdominal CT is the gold standard for diagnosis, although an MRI can give upwards to 100% sensitivity. And lastly, management includes source control, antibiotics, and nutritional support, which our patient does receive initially through NG tube and PEG. I'd like to thank you for your time, and a big shout out to all the residents and the attendings that helped me out with this. And I'd be happy to take any questions.
Thank you, Sarah. You went over about 29 seconds,
Oh,
but
shoot. I'm sorry.
you had momentum, so I didn't jump in. Janicki, maybe you can help us. That lateral and all of that white stuff. Why is all of that dotted white stuff there? Is that all?
I was
that-
waiting for someone to look at it and see what it was. It was there, I think, even in the previous.
Mhm.
It was there even in this CT. This guy's got a chronic calcified pancreatitis.
Yes.
Yeah, that's what it is.
Oh, wow, look at that.
So I was wondering why you didn't mention it,
I
because
did,
he has
sorry.
chronic calcified pancreatitis. Because
Look, oh, it's down there in the tail. Yeah, wow.
it's beautiful. Yeah,
That's
it's gorgeous.
impressive.
Yep. And
Goodness gracious.
so the thing about fluid, right? When you look at fluid here, like it doesn't have a defined wall. If you look at the fluid here, it really doesn't have a defined wall. Whereas, if you look at the fluid here, it almost seems to have like a wall around it, like a thickness around it. And whenever you see fluid on CT and it's got like this rind, that's what we call it, rind, whether it's in the pleural cavity or the peritoneal cavity or the retroperitoneal space, you got to think about a complex fluid or an infected fluid. And even here you can see like it's almost like loculation. Now, I am just amazed that we had emphysematous cholecystitis and we didn't see it on the initial CT, because I mean, CT is like very pathognomic for emphysematous cholecystitis and gangrenous cholecystitis, because you do see air, and that is one of the diagnostic criteria. Per se, when you look at a gallbladder, it is best to look at it on ultrasound rather than CT, except for the distal part of the common bile duct. That's when you need the CT. So retroperitoneal, absolutely, no doubt. CT is the diagnostic image of choice. But if you're looking at gallbladder, you always start with ultrasound because you lose out a lot of the things on other things.
Thank you, Doctor.
All right, so now in the interest of time, we thank all our presenters. And if everyone could leave the room basically, Dr. Deepak and I are going to confer, and then if you all will go to the main room, we'll be announcing the two of you who move on to the next round. So thank you very much.
Awesome
Thank
job,
you.
everybody.
Thank you.
Awesome job. Great job.
Thank you very much.
All right, let's go. So Shannon, you have you're going first, right?
I believe so, yes.
All right, here we go. Go.
Okay, my name is Shannon Toll. I'm a fourth-year medical student at Xavier University School of Medicine. I'm going to be presenting a case of a rare left-sided bilious pleural effusion in a patient with severe necrotizing gallstone pancreatitis. Biliary pancreatitis is the most common etiology of acute pancreatitis presentations in the Western world and accounts for about 30 to 70% of all cases. A rare complication of acute pancreatitis is bilious pleural effusion, or as I will call it, bilothorax. So this patient is a 59-year-old male with pertinent past medical history of Gilbert syndrome and a complicated diverticulitis, who presented to the ED with severe abdominal pain and vomiting for 2 hours. This patient was known to the admitting physicians as his surgeries took place at the presenting hospitals in both 2019 and 2020, as listed on the poster. The patient did deny both a smoking history and alcohol abuse. On physical exam, the patient was afebrile on presentation. However, he was tachycardic to the 120s, tachypnic at 22 breaths per minute, and required 3 liters of nasal cannula to maintain an oxygen saturation of 95%. Notable labs, as you can see on my poster, he did have leukocytosis with a white blood cell count of 22. The bilirubin levels were not alarmingly high. However, the elevated lipase level of 368 was concerning for pancreatitis. So the patient was admitted to the surgical floor due to his history of Gilbert syndrome. We were concerned about gallstone pancreatitis and began a workup with an abdominal CT, which confirmed our differential. And the abdominal CT did show acute interstitial pancreatitis with layering sludge and gallstones in the gallbladder. The patient became acidotic and had increasing respiratory effort, so he was intubated and had an EUS and ERCP performed. This showed a common bile duct of 4 millimeters with no obstructing stones, and the ERCP was unable to be completed due to severe edema in the duodenum.
He remained intubated post-procedure, and he was taken to the ICU for aggressive fluid resuscitation and pain management. While in the ICU, he developed worsening direct and indirect hyperbilirubinemia. A liver ultrasound did not reveal any obstructing stones, biliary ductal dilatation, intrahepatic ductal dilatation, portal hypertension, nor portal vein thrombosis. So the patient was weaned off the ventilator multiple times. However, reintubation was required. No pathology was visualized on subsequent chest x-rays until a week into his hospital course when a left-sided pleural effusion was present. A thoracentesis was performed by IR and 15 cc of non-viscous greenish bilious fluid was removed, and therefore a chest tube was inserted for further drainage. Lab testing on the fluid seen on the poster was most important for the total bilirubin of 6.4, an LDH of 1,614, and amylase of 407. On culture, no organisms were present when we sent it to the lab. Serum levels obtained at the same time resulted with a total bilirubin of 6.4 and an amylase of 33. A HIDA scan was then performed, and it showed normal hepatic and ductal morphology, and no leaks were identified. So with the insertion of the chest tube and daily drainage of this bilious fluid, the patient's respiratory status improved, his leukocytosis resolved, and we were able to extubate him and transfer him to the surgical floor. However, he was transferred back to the ICU 1 day later. He was febrile to 101.7, his leukocytosis returned, and he had increased work of breathing and lethargy. So the patient was re-intubated for airway protection at that point. An abdominal CT showed a markedly swollen and edematous pancreas with peripancreatic fluid and inflammatory changes. No retroperitoneal collections were visualized. A dynamic contrast CT was completed a few days later and showed evolving liquefaction of nearly the entire pancreas, resulting in large wall-enhancing pseudocyst with decreasing surrounding circumferential mesenteric fat, infiltration, and inflammation. And at this point in time, a plan of care discussion with the family had occurred, and it was decided to transfer the patient to a larger academic hospital for further treatment. Unfortunately, the patient did pass away from his illness shortly after the transfer. So this case illustrates left-sided bilious pleural effusion, a rare complication of severe necrotizing gallstone pancreatitis. The importance of this case is that it highlights the difficulty in diagnosis of bilious pleural effusion as the symptoms mimic other respiratory and cardiovascular pathology. Bile salts irritate the pleura, lung, and skin. If contact persists, these bile salts can cause major lung injury, including pneumonitis, fibrosis, or lung destruction, and can lead to non-cardiogenic pulmonary edema. So as you can see in figures 3 and 4 in my clinical images, aspiration of bile salts in a rat lung parenchyma shows the potential histological changes with aggregation of collagen fibers, ulceration of the mucosa, and fibrin exudate as a result of severe exfoliation of the surface epithelial cells. So this case presented here is unique in that the pleural effusion was found to be bilious in nature, was left-sided in orientation, and did not result from a bile duct leak or injury. Only 2 other cases were found that did not result from surgical manipulation of the abdominal contents or trauma. So bilothorax should be within the list of differential diagnoses in patients who have undergone hepatobiliary manipulation, have had any abdominal trauma, pancreatitis with or without gallstones, or have had hepatic infections and are showing signs of inflammation, tachypnea, tachycardia, chest pain, or overt respiratory decompensation. So early diagnosis of bilothorax decreases the destruction of the alveoli and reduces the inflammation and potential pro-fibrotic changes. Thank you.
Okay, that was perfect. That was right at 6 minutes. We have 2 minutes for questions. All right, so I have a question. Where is this? Where do you think the bile was? Where's it coming from? What is the? How is this working here?
So the thought process with this patient was that due to the degree of inflammation and the edema that was seen on the initial ERCP within the duodenum, there was potential micro tears or microabrasions within either the duodenum or some of the common bile duct, and bile was leaking out, causing irritation on the bottom of the left hemidiaphragm. And because he had so much inflammation within his abdomen that it was causing microabrasions, and the bile leaked through those abrasions into the diaphragm, or through the diaphragm into the thoracic cavity.
You guys buying that? We have a skeptical group here.
I think that's a fairly relatively reasonable explanation of what may have been happening. Some kind of moving across the diaphragm.
Okay, that great case. Thank you. Thank you. Yeah,
Thank you so much.
I apologize. If you wanted me to advance the slide, please tell me, and I'll advance your slides. Okay. I noticed that Shannon had some. You had some slides here. Okay.
I preferred it on the poster.
Yeah, that's fine.
Most of his case was within the hospital course itself, so I didn't mind it. So thank you.
Okay, the next presenter is who?
That's me, sir. Emma.
Okay. Let me see if I can.
Hi, Emma.
Hi.
Okay, here we go. Emma, where are you located now?
I'm in Norfolk, Virginia. I go to school at Liberty University, but I'm a third-year student here in Norfolk.
Okay.
Great.
I'm so glad that folks from your school heard about our meeting. Okay, so okay, I'm going to. Are you ready?
Yes, sir.
Okay, well, I'm going to go ahead and start the clock. And then tell me if you want me to advance your slide, okay?
Okay.
Okay, 1, 2, 3, go.
So you can go ahead and advance the next slide.
Okay.
So I'm going to start with a brief introduction as to where this presentation is going. Sarcoidosis is a multi-system granulomatous disease of unclear etiology. Most commonly, as we know, it presents with pulmonary symptoms, so chest pain, shortness of breath, cough, as well as constitutional symptoms, fever, and weight loss. That's usually what we think of when we think of sarcoidosis. Incidence is about 5 to 40 cases per 100,000 people. Most commonly, it is seen in African Americans, females, and there is a peak at age 20 to 39. So sarcoidosis can present in a variety of ways, one of which is Herford-Waldenstrom syndrome. It's a rare presentation of sarcoidosis. So without further ado, I'm going to get into a case. Next slide. So we have a 36-year-old African-American male with no past medical history who presented with bilateral facial swelling at the behest of his wife. Nothing was really done for it at the time. He was discharged home. He presented 2 weeks later now with fevers, night sweats, a 12-pound unintentional weight loss, dyspnea on exertion, which he described he could no longer even walk up one flight of stairs, as well as this odd forehead tingling sensation on the right side of his forehead. On physical exam, his vitals were stable. He was afebrile at the time of presentation. Exam revealed a bilateral non-tender swelling of his cheeks, about 2 golf balls in size on each side. And you can see on that CT scan of the head and neck, the swelling of the parotid glands that was going on. An exam also showed an asymmetric smile showing a facial nerve deficit as well. His lungs were clear. There was no hepatomegaly, no rashes or joint pain, and ophthalmological exam was unremarkable at this time. Next slide. So labs of significance, he did have a leukopenia at 3.39. Later, it got even lower, about 2.28. And elevated liver-associated enzymes at 72 and 81, which also increased later in his course. So a chest x-ray was obtained because of his shortness of breath, pulmonary symptoms, which showed bilateral hilar adenopathy and diffuse interstitial prominence. So a CT was obtained to better characterize it, which did show extensive lymphadenopathy pulmonary interstitial thickening and reticulation, and innumerable ground glass nodules. An EKG was also obtained. It showed normal sinus rhythm, but it did show some left ventricular hypertrophy, for which we obtained a cardiac MRI to evaluate because at this point we had seen the bilateral hilar adenopathy. We suspected sarcoidosis at this point and wanted to see if there was cardiac involvement. So we obtained that cardiac MRI, which is on the bottom right there. The arrow is pointing to a light area. It's pretty faint on the bottom there, but that shows delayed enhancement of the inferior apical wall, which is a classic finding on cardiac MRI in patients with sarcoidosis. And on the top right, that is the chest CT. The gray in the middle, in between the arteries, that's the extensive lymphadenopathy that was found. Next slide. So this gentleman did undergo bronchoscopy with lymph node biopsy, which showed non-caseating granulomas composed of spindled to epithelioid histiocytes, which is consistent with sarcoidosis. On the left, that's an example of non-caseating granuloma that you would find and expect on pathology of sarcoidosis. This was not our patient's pathology, but this is just an example. So he was started on a prednisone burst and within a week had significant improvement of his symptoms, including his facial swelling going down, improvement of his dyspnea. So this Herford-Waldenström syndrome is characterized by parotid gland enlargement, facial palsy, anterior uveitis, and fever. Our patient clearly had the parotid gland enlargement. He did show the facial palsy as well as this odd addition of possible trigeminal neuralgia as well. Anterior uveitis, he was not demonstrating any eye symptoms at this time, and the exam was normal. So sarcoidosis, the diagnosis is established based on compatible clinical and radiologic findings with support established by the histologic evidence of these non-caseating granulomas on lymph node biopsy. So our patient demonstrated all of these findings. So take-home point from this case is that while the most common presenting symptoms of sarcoidosis are pulmonary in nature, that's classically what we think of, the shortness of breath, chest pain, that sort of presentation. Clinicians should be aware of the extrapulmonary manifestations. This gentleman came in with bilateral facial swelling alone first. So that's an important thing to keep in mind. Thank you.
Okay, that was perfect. Okay, and any questions from the group?
Was there any explanation to the patient's leukopenia? And was there any concern starting the patient on prednisone giving their leukopenia?
The leukopenia, from what I understand, that there can be inflammatory infiltrate in the bone marrow. Leukopenia is a common finding in sarcoidosis. There was not concern starting prednisone at the time. It was monitored. He was started on the prednisone while he was still admitted to the internal medicine service. So he was there for about a week on the initial prednisone burst, and it did not go down any further. Actually, with steroids, you can see a leukocytosis, so it actually went up a little bit.
Thank you for that question. Emma, my understanding of Herford syndrome is that almost all the patients have fever. Now, the patient described fever at home, but you all did not find any fever at all during the hospitalization?
He was given, he presented initially to the ED, and he was given Tylenol for his fever, scheduled Tylenol. So that could very well be the reason why he was not fevering in the hospital.
And when you described, you said the ophthalmic exam was negative. That was ophthalmic exam done on the medical wards or one with slit lamp?
We did one on the wards, and then we also consulted ophtho, and they came and did an exam as well. And there were no findings of uveitis at that time.
Okay. Well, but you gave the patient an A for trying to get Hereford syndrome. Yeah. Okay.
Yeah. Great.
All right. Well, good. Well, thank you. That's a nice presentation and a nice case.
Can I ask a question quickly?
Yeah, sure.
So did you say that he also had symptoms of trigeminal neuralgia?
He did. He was explaining it as when he was combing his hair, it felt differently on the right side of his forehead. In that distribution. So that was kind of an additional finding that we didn't really know what to make of. It's not the classic presentation of Hereford. But yeah, that's what he was explaining.
Did he require any further management, or did the prednisone eliminate those symptoms?
It did. The prednisone eliminated that as well.
Okay.
Great. Who's the next presenter? I'm sorry, I don't have the list in front of me.
We're going next.
Okay.
Yassine and Mrs. Medin, and we're both third-year medical students. We're currently in Baltimore at St. Agnes Hospital.
Great.
At St. Agnes Hospital.
With Dr. Cole.
Yes.
Correct.
Okay.
Dr. Cool. Boy, don't let anybody hold on there. It's I have Yassim.
Yeah.
I have Yassim.
Yeah.
Is that the right one?
That's correct.
Okay.
Yeah, we'll keep it on.
Okay, is this your poster?
Yes, the second slide.
Okay. All right. Who's presenting?
My understanding was that we're both presenting.
Both present. And you guys are from which? You guys are from American University of Caribbean.
Yes.
Correct.
Wonderful. Okay. Let me. Oh. Okay. All right. Here we go. You guys ready?
Yep.
Okay. Go.
Okay, so today we're going to be presenting a case of a retrocardiac hiatal hernia mimicking an end-stemming. So to start, a hiatal hernia describes a slip of the gastroesophageal junction or part of the stomach through the hiatus and opening in the diaphragm between the stomach and the chest. There are 4 different types of hiatal hernias, with the most common being sliding and paraesophageal hernias. Main risk factors for this condition are obesity, aging, trauma, straining, and frequent vomiting and coughing. In an increasingly aging and overweight population, hiatal hernias are becoming far more that hiatal hernias are present in over 50% of patients over 60. Troponins are commonly used in practice to diagnose cardiac conditions. However, different pathological processes have been also associated with increased troponins, such as pulmonary embolisms and renal failure.
Now, as the patient presented, the patient was a 38-year-old female with no pertinent past medical history, who presents to the ED with a 3-day history of atypical chest pain. Patient felt sudden, crushing, mid-sternal pain at rest that radiated to her right shoulder and her right arm. Patient denied cough, shortness of breath, fever, chills, vomiting, palpitations, any anxiety or stress, or any pain with inspiration. She has a past medical history for Bell's palsy in 1995. She's currently not on any medications, and she does not have any allergies. As for her family history, her mother is alive and has hypertension and diabetes. Father also alive and has no pertinent past medical history. She has a 19-pack year smoking history with approximately 2 to 3 cigarettes per day. She denies a healthy diet or any normal exercise routine, and she's a marijuana user of 1 to 3 times per week. On vitals, on admission, her heart rate was 99, respiratory rate of 22, blood pressure of 141/91, and PO2 of 98. On physical exam, she was alert and appears in acute distress. On cardiovascular exam, she had regular rate and rhythm. Point of maximal impulse was at the 5th intercostal space, mid-clavicular line. She had no heaves and normal S1 and S2 intensity. On respiratory exam, she had normal breath sounds bilaterally, no respiratory distress, and no accessory muscle use. At this point in the hospital, we initially obtained an EKG, which showed normal sinus rhythm and Q waves in AVL, lead 1, and lead 2. We additionally ordered a chest x-ray, which showed normal mediastinal and cardiac silhouettes, and the lungs were clear bilaterally with no infiltrates. Troponins were also ordered and showed an initial elevation of 1.39 nanograms per milliliter on admission. We initially treated the patient as having an NSTEMI and administered aspirin, clopidogrel, nitroglycerin, started on a heparin drip, and also troponins were trended every 6 hours. Due to the atypical presentation of this 38-year-old female with no family history of coronary artery disease and no major risk factors, we decided we needed to rule out any additional conditions such as a pulmonary embolism, which may display a similar presentation. Thus, a CT angio with contrast was ordered. And that CT angio showed no acute cardiopulmonary process, no PE was seen, and there was no evidence of right heart strain. Although, incidentally, a moderate to large retrocardiac hiatal hernia was seen. At this point in the hospital course, hiatal hernia could be associated with the patient's presentation and elevation, though coronary pathology could not be completely ruled out. The team then decided to obtain a CTA of the coronary vessels 1 day after admission, as the patient overall symptoms at rest were completely controlled and had resolved. The CT showed no findings of occlusion, stenosis, or significant plaque. All coronary vessels were shown to be patent. Our leading diagnosis at this point favored the large retrocardiac hiatal hernia as the primary cause for the patient's recurrent symptoms, although what now becomes of great concern is the effects that this hernia may have on cardiac contractility and functioning. Thus, a transthoracic echocardiogram was ordered, which ultimately showed an EF of 70%, normal systolic wall motion, and normal cardiac filling. The patient's medications were eventually discharged, and she was told to follow up with surgery on an outpatient basis.
Now, to recap, a hiatal hernia is a herniation of abdominal contents into the thoracic cavity through the diaphragmatic hiatus. They're strongly associated with reflux esophagitis, with studies showing that up to 94% of GERD patients having endoscopic or radiological evidence of hiatal hernias. The main risk factors for this condition include age, increasing BMI, and male sex. And the most common presenting symptoms in patients are GERD symptoms, such as retrosternal pain, dysphagia, and nausea, which clearly resemble the presenting symptoms of a patient with acute coronary syndrome. However, besides MI, cardiac troponins can be elevated in other conditions, such as pulmonary embolism, renal failure, sepsis, with several case reports that have emerged of hiatal hernias mimicking cardiac chest pain, with even further evidence suggesting heart problems, such as elevated cardiac enzymes. Therefore, with an increasing prevalence of hiatal hernias in the general populations, clinicians must keep a broad differential and consider other causes of chest pain with elevated troponins, such as hiatal hernias. Thank you.
Thank you.
Okay, perfect.
This is a very interesting case. My question would be, were the surgeons not concerned about repairing the hernia sooner rather than later?
We actually did not follow up with the patient after she did go to surgery because she followed up as an outpatient, but we'd be more than happy to try and find out what happened. In the case reports that I have read, I didn't necessarily see any concern from a surgical standpoint.
Thank you.
You guys,
I have a quick question, if that's okay.
please.
What was your thought process on the initial elevated troponins? Were you thinking that it was demand ischemia? Were you worried that the size, well, I guess hindsight, the size of the hiatal hernia was causing compressive symptoms on the heart?
So we were mainly thinking that it was causing, like you said, compressive symptoms. So as it was so in that top picture, you could actually see the retrocardiac hernia really impinging upon that ventricle. And with maybe the eburnation and rubbing up against it, it could lead to some release of that troponin from the cardiac myocytes. That is also a hypothesis, but there are a lot of case reports that are showing that retrocardiac hiatal hernias do lead to elevated troponin levels. And through that mechanism that we are describing, through the compression of them coming together.
Very interesting case. What the urine, the toxicology screen was positive. Was cocaine a part of the picture here? Could that have been caused coronary spasm?
So that was what led us to our very initial diagnosis that this patient could have had an NSTEMI. But as we trended the cardiac troponins and we saw that they were dropping and we saw the retrocardiac hiatal hernia, we thought that it was more likely that the hiatal hernia was the reason for this patient's chest pain and not necessarily the drug abuse causing like a vasospastic angina or something like that.
Okay. Good. All right. Thank you.
Thank you.
Okay. I'm going to let's see here. Okay. Now the next presenter, is it let's see here, is it Kate?
Yeah, it's going to be, it's good morning, it's Karan.
Okay, here we go. Hold on.
And,
hold on. Okay. Is this your poster?
No. It's,
this one?
No, I think this is a different case presentation. We're the last ones.
Oh. Okay. You guys don't want, who's doing this one?
We both are going to do it.
I think that one's supposed to be in breakout room 1.
Yeah.
Oh, okay. Of course. But you got, hold on here. Well, hold on. Okay, you're Karen? Yeah.
Yeah, that's correct.
Whoa. Is this yours?
Yeah, that's ours.
All right. Okay, now, again, if you want me to advance the slide, just let me know. We'll go ahead and if you guys are ready, go ahead and start.
Okay. Hello, everyone. My name is Tadela Berisa. I'm a third year medical student from St. Agnes Hospital. My friend Karen, who is also a third year medical student, and I will be presenting a case of a bilateral cerebral infarct in a healthy young adult. Our case is about a 20-year-old African-American male who was brought by family to emergency department due to altered mental status for several hours. They reported he was in his usual state of health until the morning of admission. In the morning, they found him to be confused, having slurred speech, diplopia, and diffused headache. He also reported nausea and 6 episodes of non-bilious, non-bloody vomiting. He denied loss of consciousness, fall, any focal weakness, chest pain, palpitation, or shortness of breath. Past medical history, surgical history, and family history were non-pertinent. He was not taking any medication, and he has no known allergies. He lives with his uncle, works in construction. He admitted to smoking more than 5 joints of marijuana every day for several years. He smokes half a pack of cigarette per day for the last couple of years and drinks alcohol occasionally. Our review of system was positive only for what I mentioned on HPI. On physical exam, he was stable with temperature of 97.4, heart rate of 86, blood pressure of 131 systolic over 90 diastolic, and 100% saturation of room air. HGNT, pulmonary, cardiac, or abdominal exam was remarkable. On neurological exam, all cranial nerves were intact, motor strength in all 4 extremities were 5 out of 5 with good tones. Sensation, all sensation were intact. He had mild ataxia on gait evaluation, and Babinski was negative. Laboratory exam on labs, CBC, BMP, and the blood glucose all were within normal limit, and urine analysis was normal, and urine toxicology was positive for cannabinoids. As a part of stroke protocol, MRI of the brain was done, which revealed multifocal acute infarct on the bilateral cerebellum, and MR angiogram showed possible occlusion in the distal aspect of the left intracranial vertebral artery. After imaging revealed acute stroke, patient was admitted for further evaluation and management. Neurology was consulted, and they recommended to start him on low dose aspirin 81 milligram for the first 7 days, and then transition him to rivaroxaban. The patient had transient episode of atrial fibrillation in the ED that resolved without any intervention. And the echo was done, and transthoracic echo showed was positive for Babbel study, but transesophageal echo did not demonstrate any vegetation or clot. The patient remained asymptomatic and was discharged 3 days post-admission after his symptoms were improved. Now I'm going to give it to Karen.
Yeah, so this actually highlights kind of the importance of understanding non-common etiologies, especially in a young, healthy male. So we kind of saw that when focusing on patients in the age range of 18 to 55, we saw that of these patients, only 10 to 15% of all strokes happen in this age range. And the most common etiologies include cardioembolic, which accounts to up to 50%. Other etiologies, which are less common, but were also considered, were hypercoagulable states, atherosclerotic, especially in the setting of poor diet and increased obesity in this age group. Once those were all kind of ruled out, we had to think about other etiologies, and the one that came to mind was the chronic cannabis use. So in literature review, there was some information in terms of kind of how it might play a role in this. In one of the studies, it was noted that up to 17%, it was noted in up to 17% of individuals that just by chronic marijuana use, it can cause acute ischemic stroke. There was another retrospective study that analyzed frequency of use. We saw that there was up to 3 times increase in likelihood of acute ischemic stroke in individuals at least one reported use of cannabis in a month, and up to 4 times with increased frequency, which was up to more than 10 days in a month. We were also trying to analyze the exact mechanism, but there was kind of a lot of varied information in literature. We weren't exactly able to understand the mechanism. There was a lot of different ones that were proposed. There was also some sort of interest in review as well as seen in our patient, that there was some concentration of these.
Karen, we're gonna have you stop. All right, thank you. Now I can't get my thing to stop. All right. All right. Thank you. Did anybody have questions?
Yes, I have maybe just a clarification. I might have missed it. Did he have any family history of any hypercholesterolemia or LDL receptor deficiency?
So yeah, based on our review, he didn't have any pertinent family history.
Thank you.
Huh. Well, when I first saw this slide that this was a 20-year-old who had cerebral infarcts, I was thinking about, I thought you were going to give us a case of Moya Moya. But this is another possibility is vasculitis. Any chance that we could be dealing with a vasculitis in the posterior circulation?
So yeah, that was a probability that we considered, but so we did an ANA study, which was negative for him, and we kind of ruled out some of the autoimmunes as well. So it was a little less on our differentials compared to just coming from the cannabis use.
Huh. Okay. Anybody in your references in the other cases, are they tend to affect this cerebellum? Is that the where cannabinoid related cerebral infarcts tend to occur?
Yeah, so we saw an increased reporting with the posterior cerebral as well as the infratentorial. And when the patient came in with a presentation of diplopia as well as mild ataxia, kind of fit the bill for our case as well.
This is a very interesting case. Certainly a rare presentation.
Becky, here's an idea. Let's have one of the presenters from round one, room 2, start, because Dobbin and Mangley have already heard the presentation at least. Does that make sense?
From the other ones, okay.
Yeah.
Give me a second. Then let me get this off.
So either Shannon or Emma could start.
Okay, Shannon's slide has come up, and Shannon's presentation is right here. Is that good, Shannon?
I was about to offer.
Okay,
You can get started.
are we ready to get started? And I'm going to go ahead and hit the stopwatch here, Shannon. 6 minutes and then 2 minutes for questions. Ready, go.
Hi, my name is Shannon Toll. I'm a fourth-year medical student at Xavier University School of Medicine. I'm going to be presenting a case of a rare left-sided bilious pleural effusion in a patient with severe necrotizing gallstone pancreatitis. Biliary pancreatitis is the most common etiology of acute pancreatitis presentations in the Western world and accounts for about 30 to 70% of all cases. A rare complication of acute pancreatitis is bilious pleural effusion, or bilothorax, as I will refer to it from here on out. This patient is a 59-year-old male with pertinent past medical history of Gilbert syndrome and complicated diverticulitis, who presented to the ED with severe abdominal pain and a 2-hour history of vomiting. This patient was known to the admitting physicians as his surgeries took place at the presenting hospital in both 2019 and 2020, as listed on the poster. The patient did deny both the smoking history and alcohol abuse. So on physical exam, the patient was afebrile on presentation. However, he was tachycardic to the 120s and tachypnic at 22 breaths per minute. And he did require 3 liters of nasal cannula to maintain an oxygen saturation of 95%. Notable labs, as you can see on my poster, he had leukocytosis with a white blood cell count of 22. The bilirubin levels were not alarmingly high. However, the elevated lipase level of 368 was concerning for pancreatitis. So the patient was admitted to the surgical floor, and due to his history of Gilbert syndrome, we were concerned about gallstone pancreatitis. So we began the workup with the abdominal CT, and that confirmed our differential. The abdominal CT did show an acute interstitial pancreatitis with layering sludge and gallstones in the gallbladder. The patient did become acidotic and had increasing respiratory effort, so he was intubated for airway protection, and an EUS and ERCP was performed. This showed a common bile duct of 4 millimeters with no obstructing stones. The ERCP was unable to be completed due to severe edema in the duodenum. He remained intubated post-procedure, and he was taken to the ICU for aggressive fluid resuscitation and pain management. He developed worsening direct and indirect hyperbilirubinemia while in the ICU. A liver ultrasound did not reveal any obstructing stones, biliary ductal dilatation, intrahepatic ductal dilatation, portal hypertension, nor portal vein thrombosis. The patient was weaned off the ventilator multiple times during the ICU. However, reintubation was required each time. No pathology was visualized on subsequent chest x-rays until a week into his hospital course when a left-sided pleural effusion was present. A thoracentesis was performed by IR and 15 cc's of non-viscous greenish bilious fluid was removed and a chest tube was inserted for further drainage. Laboratory testing on the fluid did show that the total bilirubin was 6.4, an LDH of 1,614, and an amylase of 407. No organisms were cultured as well. Serum levels obtained at the same time did show a total bilirubin of 6.4 and an amylase of 33. A HIDA scan was performed at that point with normal hepatic and ductal morphology, and no leaks were identified. With the insertion of the chest tube and the daily drainage of the bilious fluid, the patient's respiratory status improved, his leukocytosis did resolve, and we were able to extubate him and transfer him to the surgical floor. However, he was transferred back to the ICU 1 day later. He was febrile with a 101.7 temperature. His leukocytosis did return, and he had increased work of breathing and lethargy. The patient was reintubated for airway protection. An abdominal CT at that point showed a markedly swollen and edematous pancreas with peripancreatic fluid and inflammatory changes. No retroperitoneal collections were visualized. A dynamic contrast enhanced CT was completed a few days later and showed evolving liquefaction of nearly the entire pancreas, and that resulted in a large wall enhancing pseudocyst with decreasing surrounding circumferential mesenteric fatty infiltration and inflammation. And at this point in time, a plan of care discussion was made with the family, and it was decided to transfer the patient to a larger academic hospital for further treatment. Unfortunately, the patient did pass away from his illness shortly after the transfer. So this case illustrates the left-sided bilious pleural effusion, a rare complication of severe necrotizing gallstone pancreatitis. The importance of this case is that it highlights the difficulty in diagnosis of bilothorax as the symptoms mimic other respiratory and cardiovascular pathology. So bile salts irritate the pleura, lung, and skin, and if contact persists, can lead to major lung injury, including pneumonitis, fibrosis, or lung destruction, and can lead to non-cardiogenic pulmonary edema. So if you go to the clinical images slide, I think it's one previous, you can see on figures 3 and 4 there, aspirations of bile salts in rat lung parenchyma shows potential histological changes with aggregation of collagen fibers, ulceration of the mucosa, and fibrin exudate as a result of severe exfoliation of the surface epithelial cells. So in conclusion, this case presented here is unique in that the pleural effusion was found to be bilious in nature, was left-sided in orientation, and did not result from a bile duct leak or injury. The only other 2 cases were found that did not result from surgical manipulation of abdominal contents or trauma. Bilothorax should be within the list of differential diagnoses in patients who have undergone hepatobiliary manipulation, have had any abdominal trauma, pancreatitis with or without gallstones, or have had hepatic infections and are showing signs of inflammation, tachypnea, tachycardia, chest pain, or overt respiratory decompensation. Early diagnosis of bilothorax decreases the destruction of alveoli and reduces the inflammation and potential pro-fibrotic changes. Thank you.
Thank you, Shannon. Just under the wire of 6 minutes there. How do you account for, so air and bile got in the left chest cavity, right?
Yes.
And what is your hypothesis? Why did air and bile get there?
So what we were thinking was that due to the degree of inflammation, because the ERCP was not able to be performed due to severe inflammation within the duodenum, the papilla was not seen. We thought that with that degree of inflammation, that potentially there was some microabrasions or microtears either in the duodenum or in the common bile duct that weren't overt leaks seen on the HIDA. And then that bile salt within the abdominal cavity irritated the left hemidiaphragm and created microabrasions that allowed the leak and bile to go through into the thoracic cavity.
I see. Interesting. Other questions?
So I would have loved to see the images, like the actual CT images in this case, which have been beautiful, right? So one, yes, when you see a left-sided effusion, one of the differential diagnoses as a pulmonologist is always something to do with pancreas, and you have to think about bile is the lung's enemy. We see this all the time in patients who aspirate, And if they aspirate bile, then their ARDS is much worse than any other regular ARDS. So those are things that we do see. Unfortunately, this is the outcome for these patients who have very severe bilothorax and also develop other complications because the bile just doesn't allow healing. So, it was a good case, but it's a sad case.
I see Dobbin is on board. That's great. I don't think Mangla is on board yet. So
I was texting her again.
maybe you can put Emma's presentation up next, Janaki.
Sure, absolutely, we'll do that. So.
Dobbin, we're going with the two presenters from your first room, since you've already heard them, giving Mangla a little more chance to get on board for the final two presentations.
That's fine.
So, Emma, I'm going to go ahead and set the stopwatch here. And are you ready?
I am.
Emma, you can tell me if you want me to advance the slides, because sometimes otherwise I advance it incorrectly.
All right, Emma, here we go.
Okay.
Start.
Proceed to the next slide, please. So to start with a brief introduction, sarcoidosis is a multisystem granulomatous disease of unclear etiology. Most commonly, it presents with pulmonary symptoms like shortness of breath, chest pain, as well as constitutional symptoms like fever and weight loss. That's classically what we think of when we think of sarcoidosis. The incidence is 5 to 40 cases per 100,000 people. Most often we see this disease in African Americans, females, and with a peak age between 20 and 39. So sarcoidosis can present in a variety of ways, one of which is the rare presentation Herford-Waldenstrom syndrome. So without further ado, I'll proceed to the case. You can proceed to the next slide. So we have a 36-year-old male with no past medical history who presented with bilateral facial swelling at the behest of his wife. Nothing came of this initial admission. He was discharged home, lost to follow-up. 2 weeks later, he presented with worse swelling, now with fevers, night sweats, a 12-pound unintentional weight loss, dyspnea on exertion, saying that he could no longer walk up one flight of stairs, as well as this forehead tingling sensation, describing it when he was running a comb through his hair, he was feeling pain and tingling on the right side of his forehead. Vitals were stable. He was afebrile at this time, as he was given a Tylenol in the emergency department. Exam revealed bilateral non-tender swelling of the face, about 2 golf balls in size on each side. As you can see in the CT scan on the left, that is pretty significant swelling of the face. So his lungs were cleared to auscultation. There was no hepatomegaly, no rashes, joint pain. And of note, the ophthalmological exam was unremarkable at this time. Next slide. So labs of significance, he did demonstrate a leukopenia at 3.39. Later in the course, it got even lower to 2.28, as well as elevated liver-associated enzymes at 72 and 81, which did also increase as in his admission. So a chest x-ray was obtained due to his shortness of breath, which demonstrated bilateral hilar adenopathy with diffuse interstitial prominence. So with these findings, we went forward to obtain a chest CT, which you see on the top right hand of the screen, which showed extensive lymphadenopathy, as well as interstitial thickening and reticulation with innumerable ground glass nodules. So at this point, sarcoidosis was expected with a chest CT as that. EKG was obtained, showed normal sinus rhythm as well as left ventricular hypertrophy, which is why we obtained a cardiac MRI to see if there was cardiac involvement of this sarcoidosis. So on the bottom right-hand screen, the arrow is pointing to a very faint area, faint white area there. That is the delayed enhancement in the inferior apical wall, which is a classic finding on cardiac MRI in patients with sarcoidosis. Next slide. So this gentleman underwent bronchoscopy with lymph node biopsy, which showed non-caseating granulomas composed of spindle to epithelioid histiocytes, which is consistent with the diagnosis of sarcoidosis. The picture on the left is not our patient's pathology, but it's an example of that non-case-eating granuloma that you'd expect in sarcoidosis. He was started on a prednisone burst and showed significant improvement of his symptoms in just a week. So he was put on long-term prednisone therapy with pulmonary outpatient follow-up for continual follow-up on his condition. So Herford-Waldenstrom syndrome, this rare presentation of sarcoidosis, is characterized by parotid gland enlargement, facial palsy, anterior uveitis, and fever. So our patient clearly showed the parotid gland enlargement. Facial palsy, he did demonstrate an asymmetric smile on presentation on physical exam, showing a cranial nerve 7 deficit, as well as this odd finding of trigeminal neuralgia too, which is not characteristic, but it was an additional finding that improved with prednisone treatment as well. There were no eye symptoms or findings on ophthalmological exam at this time in this particular patient, but he did demonstrate subjective fevers at home as well. So diagnosis of sarcoidosis is established based on compatible clinical and radiological findings supported by that histological evidence of those non-case-eating granulomas, which our patient did demonstrate, confirming the diagnosis of sarcoidosis. So while the most common presenting symptom of sarcoidosis are pulmonary in nature, it's classically what we think of when we think of sarcoidosis is shortness of breath and those sorts of symptoms. It's important that clinicians be aware of the extrapulmonary manifestations so that the diagnosis is not missed, such as with our patient. He presented with this bilateral facial swelling, which turned out to be, in fact, sarcoidosis.
Very nice. So just, it's my pet peeve, and it's every pulmonologist's pet peeve. So the diagnosis of sarcoidosis, it's not just non-necrotizing granulomas with epithelioid histiocytes, it's ruling out every other pathology that causes it. So you have to, when you write that something is biopsy-proven sarcoidosis, you have to include AFB, GMS stains for fungal organisms. You have to exclude patient is vaping, because there are now newer cases of vaping-related granulomatous lung disease. You have to rule out beryllium exposure. You have to rule out other occupational diseases, like people in the World Trade Center developed a sarcoid-like illness. So you have to rule out all of this and then call it sarcoid. The treatment is the same. Most of the lung diseases in the acute phase we treat with steroids, right? So, but before you give someone the diagnosis of sarcoidosis, you have to make sure that you rule out all these other conditions. Can beryllium present with Herford-Waldenstrom syndrome? We don't know enough, but there are cases reported of it. So that is why narrowing it too quickly becomes a kind of thing that we pulmonologists get a little upset about, because the sarcoid-like illness can be present in multiple diseases. So that's important. Now, this CT does not have reticulation. This CT has septal lines. This CT has ground glass opacities. It has much more upper lobe predominance. But when you look at the CT, the first thing you're thinking is volume and a perilymphatic distribution, which again is seen in sarcoid, it's seen in beryllium, it's seen in fungal infections, it's seen in lymphangitic carcinomatosis. So that is another important thing. The delayed enhancement is definitely one of the things you see in infiltrative diseases, and sarcoid is one of those infiltrative diseases you think about. So absolutely, like Herford-Waldenstrom is one of the presentations of sarcoidosis. We have seen quite a few cases of it. And the other big one is Lofgren's, right? And Lofgren's is usually self-limited. And these are other things you think about of sarcoidosis instead of the traditional pulmonary sarcoidosis, which most of the times actually is not symptomatic. It's just found on random imaging for something else. So very good case, very nice.
Quick question, Emma. The cranial nerve 7, was that a peripheral 7th? Was the upper face also involved?
It was, yes. It was
Yeah.
an entire hemifacial droop.
Yeah. Logic would say it should be. Thank you. Well, Mary, I think you're going to be next up. Janica, you ready?
I am.
Sounds good. Okay, so hello, when you're ready, Dr. Williams.
Okay, I am ready.
Okay, hi everyone, my name is Mary Malati. I am a medical student at the University of Maryland, and I would like to first begin my presentation by thanking Dr. Sama, who was my attending in my internal medicine rotation, who took out time out of his busy schedule to offer guidance on my first case report. So this morning I will share with you the case of a middle-aged man who presented with invasive pneumococcal pneumonia as his primary symptom of multiple myeloma, and some lessons to be learned. Can you please advance 2 slides? Again. So a 55-year-old man with history of substance use disorder, hypertension, and asthma presented to the ED with a 3-day history of diarrhea, nausea, and vomiting. He was found to have a fever of 101.2 and was hypoxic to 86% on room air. A chest x-ray revealed an extensive hazy left lower lobe infiltrate concerning for pneumonia. His laboratory data was notable for leukocytosis of 22.5, anemia with a hemoglobin of 5.7, and acute kidney injury with a creatinine of 8.9. His calcium level and paraprotein gap were within normal limits. In blood cultures grew streptococcal pneumonia, and a streptococcal urine antigen was also positive, confirming sepsis. So, given such an invasive pneumococcal infection in an otherwise healthy man, the decision was made to investigate immunodeficiency. HIV antigen and antibody were found to be negative. Hepatitis and rheumatological workup were also negative. Next slide, please. So here in figure 2 in the middle is a CT of his abdomen and pelvis, which showed a lytic lesion in the right iliac wing. The pelvic MRI, which is in figure 3, also showed the right iliac wing lesion and also a left femoral lesions and brought concern for neoplasm. The answer to this case was in the multiple myeloma and immunoglobulin deficiencies workup that were obtained. Both SPEP and UPEP showed a discrete band in the gamma region, and immunofixation showed a discrete lambda light chain band with trace IgG band. Kappa lambda ratio was low at 0.03, which meant that there's an excess production of lambda light chain. A bone marrow biopsy was scheduled, but unfortunately the patient left AMA stating mistrust of the hospital. And a few weeks later, he presented to an outside hospital with similar symptoms of fatigue and anemia, for which an IR bone marrow biopsy was performed and confirmed the diagnosis of multiple myeloma. Next slide, please. So there are a few lessons to extract from this. As you may know, multiple myeloma is a clonal proliferation disorder of plasma cells in the bone marrow that usually presents with bone pain, renal failure, hypercalcemia, fatigue, and weight loss. It is also known that patients with multiple myeloma have a higher susceptibility to encapsulated bacterial infections compared to the general population. This is thought to be due to the diminished production of functional immunoglobulins and a defect in the patient's C3b binding capacity to strep pneumo to clear it from the body. There are only a few cases reported with severe bacterial infection as the primary presenting symptom of multiple myeloma. A review paper of 17 case reports from 1978 to 2008 of bacterial infection as the first presenting symptom of multiple myeloma summarized the findings. Musculoskeletal infections, specifically septic arthritis, predominated these cases, followed by pneumonia, which was 29% of the cases. The culprit was strep pneumo, which was found in 2/3 of the infections, followed by H. influenza. And bacteremia was present in 80% of these cases, as in my case. So the case I present to you this morning highlights the importance of considering multiple myeloma in previously asymptomatic middle-aged patients who presents with an acute severe bacterial infection without an apparent predisposing factor. In addition, this case report points out to the challenges faced by patients with concurrent comorbidities like substance use disorder or socioeconomic challenges that may prevent them from staying in the hospital to get tests and obtain optimal medical care. Ideally, patients would be treated for their infection at the hospital and follow up with a hematology clinic to prepare for chemotherapy and possible stem cell transplant. But in the real world, there are many obstacles to managing this disease, which could delay diagnosis. And in the literature, it's known that delayed diagnosis of multiple myeloma decreases the time of disease-free survival. The last fact I'll share is that multiple myeloma is more common in older patients, particularly 65 to 74-year-olds. But my patient was only 55 years old. So future directions of this study from this case report could be to investigate the age distribution of patients presenting with bacterial infection as the first symptom of multiple myeloma, so we can better manage the diagnosis of multiple myeloma in all our patients. So this concludes my presentation, and I would welcome any questions.
Thank you, Mary. Dobbin, this is the first time you've heard Mary's presentation. Do you have any questions?
So was a bone marrow performed?
Yes, eventually, so a month later after this presentation, bone marrow biopsy was obtained, and it was in an outside hospital. And unfortunately, I didn't have access to the crisp, full results of how, the pathology and things like that. But it was confirmed at an outside hospital that he had multiple myeloma.
Oh, wait, so they biopsied that lesion in the hip, which was probably a plasmacytoma, but a bone marrow examination would show a plasma cell to a great extent in the bone marrow.
Mm-hmm.
So they did a bone marrow, Mary, or did they?
Sorry, what did you say?
Did they do a bone marrow or did they biopsy the lesion in the iliac vein?
They did a bone marrow biopsy from the right iliac wing.
Okay. So not the lytic lesion at a different place, I presume.
I'm trying to remember. I was reading this from
because
kind of this.
They won't call it a bone marrow if they are biopsying the iliac wing itself. They would call it differently because it's usually the top is what they biopsy on the bone marrow, right, Dr. Chow?
Well, I'm not an expert of this, so I hesitate to.
Yeah, because when I've seen them biopsying at the bedside, they usually get it from the
iliac crest.
Crest.
They get it from the iliac crest.
Oh, I see.
That's how I know it. I'm no expert on this either.
Oh, I apologize. Yeah.
Okay. So Sarah, you're up next. Janaki, can you?
Yes, sir. Will do.
All right.
I should have done this in the first time too, right, peoples? Yes.
And let me get the stopwatch going here.
Okay, there we go.
Sarah, are you ready?
Ready, sir.
All right. You're on.
Perfect. Good morning. My name is Zara Halim from the American University of Antigua. Today, I will be presenting to you a case of a retroperitoneal abscess, which is our secret behind the curtain. Essentially, these are quite rare and potentially life-threatening infections given their variable and indolent presentation and often occur following gastrointestinal or genitourinary tract infections or perforations. In the Western world, or the developed world rather, it's more commonly seen in patients with Crohn's disease or in children following appendiceal ruptures. In regards to its association with biliary tract procedures, they're quite uncommon. However, have been noted in literature following laparoscopic cholecystectomies. Today, I present to you a case of a retroperitoneal abscess following an open cholecystectomy. So a 64-year-old gentleman presented to our emergency department with worsening abdominal discomfort, lack of appetite, difficulty sleeping, and just some mild shortness of breath occurring for the past 3 to 4 days. On initial presentation, he was in and out of it. However, he was able to convey that he had a lack of fever, denied any diarrhea, any vomiting, any history of HIV or immunosuppressive medications. However, he did have a history of hypertension and untreated hepatitis B and hepatitis C. Additionally, he had a long history of alcohol use, was a chronic smoker, and had a history of opioid use. Initially, his vital signs revealed hypotension, tachycardia. He had a very low BMI, as well as he was afebrile. His initial labs revealed anemia down to 4.6, leukocytosis, thrombocytopenia. His electrolytes were quite deranged, and he had a metabolic acidosis with an elevated lactate to 3. A bedside ultrasound revealed a positive Murphy sign, as well as a dilated gallbladder. Given this, his hemodynamic instability, he was upgraded to the ICU, which we will appreciate on the next slide. Yes. And when he arrived, he received the appropriate care with the IV fluid resuscitation, PPI for potential bleed, RBC units which brought his hemoglobin up till 9, as well as appropriate pressure support and antibiotics. However, he failed to improve. Given this, a GI pathology was highly suspected, so a CT angiogram of the abdomen was done, which we can appreciate in this image by the black star in the axial plane, a rather large gallbladder, as well as pericholecystic fluid, and some stones were appreciated. Additionally, on the sagittal plane, we do appreciate some free fluid in the abdomen. However, no organized abscess was appreciated. Additionally, given his long history of alcohol use, he had chronic calcific pancreatitis as well. After this, he had an open urgent cholecystectomy done, which revealed gangrenous cholecystitis and retroperitoneal exudates, for which a drain was placed. He was returned to the ICU, and he improved with adjunct antibiotics over the past 3 to 4 days. And he was subsequently downgraded to the medical floor, which we will see on the next slide. On the medical floor, however, 5 to 6 days post-op, he began to deteriorate. His mental status was in and out. He was just barely tolerating his liquid diet. He had increasing abdominal discomfort, some loose stools, and increasing purulence from the drain. The IV antibiotic regimen was extended with minimal improvement. So a CT abdomen was done, which we see here in this image. And as you can see on the sagittal plane on the right side, we're able to appreciate a multiloculated, rather large retroperitoneal abscess extending all the way down to the scrotum. This warranted IR-guided JP drain placement, which released quite a bit of purulent fluid. However, he still failed to improve significantly. So with suspicion of a potential obstruction in the biliary tract, a HIDA scan was done, which revealed a kink in the distal part of the common bowel duct and a biliary leak with extravasation of bilious fluid into the paracolic gutters. This was confirmed with an ERCP, a sphincterotomy was done, a stent was placed, and after which, with adjunct antibiotics, his clinical condition much improved. And he was discharged to a nursing home with about 4 weeks of antibiotics, as well as a follow-up 2 months later for stent removal. Next slide, please. This case emphasizes the importance of early diagnosis and also just considering a retroperitoneal abscess in patients following an open cholecystectomy. These are rather rare infections, and we do not have an established criteria, but some risk factors to consider include his advanced age, his male gender, his history of malnutrition. Additionally, those with inflammatory bowel disease, immunosuppressive medications, or even malignancy and diabetes are considered as well. The common bile duct, the distal part of the common bile duct is located retroperitoneally. Therefore, if one has an obstruction due to a stone or a perforation secondary to either a stone or a mechanical damage, in our case, such as the open cholecystectomy, can result in extravasation of biliary fluid as well as biliary flora into the retroperitoneum. This can lead to our retroperitoneal infection and potential abscess that we saw in our patients. So essentially, the mainstay of management includes source control, which we completed with a cholecystectomy and stent placement, IV antibiotic course, which was quite prolonged, as well as nutritional support, which our patient initially received with NG tube and PEG tube. So 3 take-home points we'd like to emphasize include that please consider a retroperitoneal abscess in a patient who does not improve following an open cholecystectomy. The gold standard for diagnosis is abdominal CT, and the mainstay of management includes source control, antibiotics, and nutrition. A big thank you to all the residents and attendings who helped me out, and I'd be happy to take any questions.
Thank you, Zara. Right on time. And Davin, any questions?
So do you think the cause of the leak was related to this kink in the
Yes.
common bile duct?
Yes. So we believe that. So he had an initial HIDA scan as well as a right upper quadrant ultrasound done for initial diagnosis of cholecystitis, and that did not reveal a leak. But later on, when he had the repeat HIDA scan done, it did reveal a leak. So we suspect that this potentially happened post-op or intraoperatively. And the fluid that had accumulated initially, we believe came from the gallbladder wall itself as opposed to the kink.
So if that was the case, then it would be bilious. The nature of the fluid would be bilious rather than abscess.
Yes, that's true too. That would make sense. I think he also had a potential infection of the remainder of the biliary tree, a cholangitis.
Sarah, when the IR drained this, do you know exactly what the fluid looked like?
I do know that it grew Klebsiella pneumonia and E. coli, but I do not recall the other characteristics. Sorry.
As Dr. Chow said, you would think it would have some dark brownish look to it.
Yeah, that's true.
Other questions? All right, we thank all of our presenters. And now if you all would be kind enough to leave this room, and then we'll meet you back in the main room when the announcements are made.